The trauma room went dead quiet the moment Dr. Harlan Voss threw the chart across the counter. Who authorized this dosage change? Nobody answered. Then Claire Sutton stepped forward. The woman who'd spent the last 4 months mopping floors between patient rounds, the one the senior nurses called the mop nurse behind her back, the one Voss had publicly told to stay out of his cases. "I did," she said. Voss turned slowly. The room held its breath. 3 residents, 2 techs, a scrub nurse pretending to organize a tray. "You did," he repeated, quiet, dangerous. The patient was in early septic shock. The ordered dose wasn't enough. The laugh that came out of him wasn't kind. "Get her out of my department." Nobody in that room knew, not one single person, that the woman Voss just humiliated had once kept 4 special operations soldiers alive in a collapsed building under active fire, with nothing but a field kit and 12 minutes before the roof came down. Before I go any further, if this kind of story is what you come here for, hit subscribe and follow this one all the way to the end. Drop a like, and leave a comment telling me what city or country you're watching from. I want to see exactly how far this story travels. Now, let's go back to where it started. Ridgecrest Memorial Hospital sat at the edge of Tucson the way a lot of things sat at the edge of things in that city. Functional, slightly overextended, and proud of it in the way institutions get proud when they've survived long enough to develop a reputation. It wasn't the best hospital in Arizona. It wasn't trying to be. What it was busy. 312 beds, a level 2 trauma center, and a surgical wing that had been ranked in the top 15 in the state for 4 consecutive years, largely because of one man. Dr. Harlan Voss. He was 51, broad-shouldered, gray at the temples in a way that looked intentional, and he moved through the hospital like the hallways had been designed around him, which, in a certain sense, they had been. Voss had brought in more grant funding than the last 3 chiefs of surgery combined. He'd recruited 3 department heads, personally renegotiated the hospital's contract with its primary insurer, and perhaps most importantly, he had never lost a patient on the table in 11 years of active surgery at Ridgecrest. The administration knew it. The board knew it. The residents knew it. Voss made sure of that last part himself. Claire Sutton had been working at Ridgecrest for 4 months. She had taken the position as a floor nurse in the medical surgical unit, which was not where someone with her credentials would normally land. She held an active RN license, had completed advanced trauma training, and her application listed 12 years of nursing experience with a gap, neatly explained as family medical leave to care for a parent. The hiring manager had been slightly puzzled by the gap and by the vagueness of the references, but Claire had been calm and specific in her interview, and the unit was 3 nurses short, so the questions got softer and the job offer came on a Tuesday. She was 38 years old, and she looked tired in the way people look tired when the tiredness is structural, built into them over years rather than accumulated over bad nights. She was lean, medium height, brown hair pulled back in the kind of functional ponytail that said nothing about style and everything about keeping things out of your face when your hands are occupied. She spoke quietly. She never argued with the charge nurse about assignments. She took the overnight shifts nobody wanted and the difficult patient rooms that the younger nurses passed around like a punishment, and she did all of it without complaint, which was, it turned out, its own kind of problem. Nurses who don't complain make other nurses nervous. It reads as either arrogance or damage, and either one puts people off. She'd had 2 warnings in 4 months. The first came 3 weeks in, when she'd flagged a medication interaction that the attending hadn't caught. She'd been right. The attending had been irritated. The warning cited her for communicating outside the established chain of care protocols, which was the institutional way of saying she'd made someone feel embarrassed. The second warning came 6 weeks later, when she'd spent 20 minutes with a post-op patient who was showing signs of developing compartment syndrome in his lower leg. She'd documented it, reported it to the charge nurse, and then, when the charge nurse was called away and 40 minutes passed without anyone addressing it, she'd gone back and called the on-call resident directly. The resident came, looked, agreed, escalated. The patient was fine. Claire got written up for bypassing nursing hierarchy. She'd read both warnings, signed them, and filed them away. What she didn't do was change anything, which was either impressive or infuriating depending on where you were standing. The morning of the chart incident started the way most mornings started in the MedSurg unit, short-staffed, behind on 2 patient assessments, and with a call light going off in room 14 that nobody was answering because the night shift had dumped a complicated discharge situation onto the day team without proper handoff notes. Claire was in the middle of helping a 60-year-old man named Gerald with his breakfast tray when the overhead page went out for a nursing consult in the surgical pre-op bay. She covered Gerald's tray, made sure his call button was within reach, and went. The pre-op bay was a long room with curtained bays and a central nursing station, and it smelled like antiseptic and whatever the morning maintenance person had used on the floors. Voss was already there when Claire arrived. He was standing at the central station with 2 residents flanking him and the charge nurse from surgical prep, whose name was Donna, hovering at the edge of the group with the particular posture of someone who desperately wished they were somewhere else. The patient in Bay 3 was a 54-year-old woman named Sandra Kowalski, who was scheduled for an elective colectomy in 2 hours. Claire had worked with Sandra the previous evening, had done her pre-surgical assessment, and had flagged a potential concern in her notes about the anticoagulant overlap protocol. Sandra had been on a medication for a cardiac arrhythmia, and the transition timing between that medication and the pre-surgical anticoagulation protocol had a narrow window that the initial orders didn't quite account for. Claire had noted it, adjusted the morning dosage within the standing orders the attending had written, and documented it completely. That was the chart Voss had thrown across the counter. "I asked who authorized this," Voss said, not looking up. He was reading the note Claire had written. "This isn't what I ordered." "It's within the standing order parameters," Claire said. "The timing adjustment was, I know what it is." He looked up then. He had pale eyes that didn't warm much when they focused on a person. "What I'm asking you is who told you to override my protocol?" "I didn't override it. I documented a timing adjustment within the range your standing orders allow for bridge therapy. The pharmacist confirmed." "I didn't ask what the pharmacist confirmed. I asked what you thought you were doing." He turned to Donna. "Is this a nurse from your unit?" "She's from Med-Surg," Donna said carefully. "She did the pre-op assessment last night." "Then she should stay in Med-Surg." Voss set the chart down. Flat, precise. He looked at Claire the way a man looks at something he doesn't find interesting enough to be angry about. "You're a floor nurse. You document what you observe, and you execute what you're ordered. You don't make clinical decisions in a surgical case." The patient's INR was trending outside the safe surgical window. "If she goes to the table at the original dosage timing, do not." His voice didn't rise. That was somehow worse. "Do not finish that sentence like you know more about surgical preparation than I do. I have been doing this for 20 years. You have been here 4 months. Do you understand what I'm telling you?" The 2 residents were both looking at the floor. Donna was looking at the wall. The other nurse in the room, a young woman named Tasha, who was technically the one who'd paged for the consult, had gone very still by the supply cabinet. Claire looked at Voss. She didn't look away, and she didn't look afraid, which was either bravery or a certain kind of exhaustion that looked similar. "I understand," she said. "Good. Then go back to your floor, and if you ever touch one of my pre-op charts again without direct authorization from me or my resident, you'll be having a very different conversation. Not with me, with HR." He picked the chart back up and turned away from her as completely as it was possible to turn away from a person in a shared room. "Donna, I need the corrected order sheet." Claire left. She walked back through the corridor at the same pace she'd arrived at, which was a controlled and deliberate pace, and she turned into the staff bathroom near the elevator bank, ran cold water over her wrists for about 30 seconds, and then dried her hands, looked at herself in the mirror for a moment, and went back to work. Room 14's call light was still going off. The patient in room 14 was a 71-year-old man named Walter Reyes, who had come in 2 days ago with a hip fracture following a fall in his garage. He was 4 hours post-op from his hip replacement, slightly confused from the anesthesia, and deeply unhappy about the catheter. He was also, Claire noticed when she came in, and went through the quick visual check she'd learned to do without making it look like a visual check, slightly more flushed than he'd been an hour ago, and his respiration was running faster. "Mr. Reyes, it's Claire. How are you feeling?" "Hot," he said. "And this thing—" He gestured at the catheter line with profound irritation. "I want it out." "I know. Let me check a few things first." She took his temp. 38.6. She checked his incision. Nothing visible at the dressing. She checked his calf. There, just there, a tightness in the left leg that hadn't been present in the previous assessment. She asked him to tell her on a scale of 1 to 10 how his leg felt. Not the hip, the lower leg. Maybe a 4, he said. Just kind of pressury. She documented everything, pulled out his chart, and looked at the orders. Then she went to the nursing station, where the charge nurse, a man named Barry, who was technically competent and temperamentally averse to complications, was eating a breakfast sandwich and reviewing staffing numbers. I need a DVT workup on Reyes and 14, she said. Left calf presentation, slight fever, his legs showing early signs of tension. Barry chewed. He's 4 hours out of a hip replacement. Some swelling is normal. This is different from normal stop swelling. The firmness pattern is, I'll flag it for the afternoon rounds. Barry, she kept her voice even. If this is a DVT and it moves, we're looking at a pulmonary embolism. He's 71 and his cardiac history puts him at elevated. I know his cardiac history, Claire. I read the same chart you do. Barry set down his sandwich. He wasn't a cruel man. He was a tired man running a unit that was perpetually understaffed. And what he wanted in that moment was to eat his breakfast sandwich without someone bringing him a problem that would require 3 phone calls and a flurry of documentation. I'll put a note in for rounds. That's appropriate protocol. She knew what appropriate protocol was. She also knew what 4 hours of waiting could mean for a 71-year-old man with a clot forming in his left calf. She went back to Walter Reyes, did a more thorough Hohmann sign assessment, equivocal but present, and pulled up the attending's standing orders. There was a clause. She documented it. She called the attending's answering service directly, gave a clear clinical summary, and had an order for a stat Doppler ultrasound within 11 minutes. The ultrasound confirmed a DVT. Walter Reyes was started on anticoagulation therapy that afternoon. His daughter came in the evening and cried in the hallway, not because anything bad had happened, but because something bad had not happened, and she was old enough to understand the difference between those two things. Barry said nothing to Claire about it. Voss, 2 floors up, was not aware it had occurred at all. But Sandra Kowalski's surgery was delayed 2 hours while the corrected anticoagulation protocol, the one Claire had flagged, the one Voss had rejected, was reviewed by the cardiac team and ultimately implemented. The surgery went fine. Nobody mentioned why the delay had happened. Nobody mentioned Claire. 3 weeks passed in the particular rhythm of hospital work, which is not really a rhythm at all, but a series of controlled emergencies separated by paperwork. Claire worked. She was good at it in the way people are good at things they've been doing under conditions far more difficult than the current ones. Competently, without flair, with the kind of muscle memory that doesn't need to think itself through. The other nurses on the unit had sorted themselves into 3 camps with regard to Claire. The first camp consisted of the nurses who were simply too busy to form an opinion. The second camp consisted of nurses who found her mildly unsettling. She was too quiet, too precise, and she didn't gossip, which in a unit where gossip was the primary social adhesive, amounted to a kind of social non-participation that read as judgment. The third camp consisted of Tasha, the young nurse from the surgical pre-op bay who had been in the room during the chart incident, and who had started working the same corridor as Claire 3 days later, and had, over the intervening weeks, graduated from cautious observation to something approaching actual conversation. "Can I ask you something?" Tasha said one afternoon. They were in the break room, which was a narrow room with a table, 4 chairs, a microwave that smelled like someone had heated fish in it circa 2019, and a coffee maker that was technically functional. "Sure," Claire said. "When Voss did that thing, the chart thing, you didn't look scared." Claire poured coffee. "Should I have been?" "He's gotten 2 nurses transferred off this floor in the last year. One of them filed a complaint with the nursing board and it went nowhere. Tasha paused. "He's got a lot of pull." "I know. So you're not worried?" Claire looked at her coffee. "I'm not here to make enemies. I'm not here to make friends either. I'm here to make sure the patients are okay." She took a sip. "The rest of it is just weather." Tasha thought about that for a moment. "That's either the most zen thing I've ever heard or really depressing." "Probably both," Claire said, and went back to her rounds. The accident happened on a Wednesday. A tanker truck lost its brakes on Interstate 10 heading into Tucson and rear-ended a tour bus carrying 42 passengers, most of them elderly retirees on a Southwest Canyon tour. The secondary collision involved 3 additional vehicles. By the time the first dispatch call went out, there were confirmed fatalities at the scene and an unknown number of critical injuries. Ridgecrest Memorial wasn't the closest hospital, but it was the nearest Level 2 trauma center, and within 35 minutes of the initial dispatch, the emergency department had activated a mass casualty protocol and the first ambulances were arriving. Claire was on hour 7 of a 12-hour shift when the overhead page went out. She finished what she was doing, documenting a post-procedure note on a patient in room 9, and then went to the charge desk and asked Barry where she was needed. Barry, who in mass casualty situations became a different and marginally better version of himself, looked up from the whiteboard. They're asking for anyone with trauma experience to report to the ED support area, but I need bodies on the floor. I've got 4 patients who are going to need— Which 4? Claire said. He listed them. She ran through them in her head. 2 of them are stable. 1 needs a check in 30 minutes. I'll have Tasha cover. The 4th, Marcelli in room 6. He needs eyes on him. He's been trending toward fluid overload since this morning. Can you sit on him? Barry blinked. Yes, I can do that. I'll send Tasha your way. She was already moving. I'll check back. The ED during a mass casualty event is a particular kind of organized chaos that people who haven't experienced it sometimes mistake for disorder. It isn't. It's closer to a controlled burn, destructive in a directed way, with people moving fast along established channels, even when everything around those channels is falling apart. Claire had been in 3 mass casualty events in her life, 2 of which had occurred in places and conditions that the people now rushing through this emergency department would not have been able to imagine. She set that aside and moved to the triage area. The charge nurse at the door, a stocky man named Dom, who looked like he hadn't slept in 30 hours even before the accident, handed her a color-coded vest and a clipboard. You trauma trained? Yes. Where? She paused for about half a second. Extensive field experience, 12 years. Dom looked at her. He was the kind of nurse who could read people in about 4 seconds, because he had been doing it for 23 years and his survival in this job depended on it. Whatever he saw in those 4 seconds made him nod. Bay 7. We've got a woman, 64, GCS of 12, chest trauma, suspected internal bleed. The resident in there needs a second set of hands. She went to Bay 7. The resident was a second-year named Dr. Patel, young, focused, sweating through his scrub cap. And the patient was a woman named Grace Ellerman, who had been in seat 12 of the tour bus and had gone into the seat in front of her chest first when the collision hit. Her ribs were cracked on the left side, which the X-ray that someone had managed to run showed clearly enough. But what the X-ray didn't fully capture, and what Claire noticed within 60 seconds of being in the bay, was the way Grace's trachea was positioned. Just barely, just slightly off-center, and the way her breath sounds on the left were not absent, but diminished in a pattern that was different from a simple pneumothorax. What's her O2? Claire asked. 91 and dropping, Patel said. Trachea's deviated. Left side breath sounds are reduced, but there's a friction component. She was already reaching for the monitoring leads to check the rhythm. I think you've got a hemothorax developing rather than a simple pneumo. She needs a chest tube rather than needle decompression. Patel looked at her. You're the nurse from— Chest tube, Claire said. Not loud, just precise. If this is blood in the pleural space and we needle decompress, we're going to accelerate the problem. Patel hesitated for 2 seconds. The 2 seconds of a person cross-referencing what they're hearing against what they know, trying to figure out if the person talking knows what they're talking about. And then he turned to the supply tech. Get me a chest tube tray. He was right to hesitate. He was right to check. And he was right to call it. They placed the chest tube. The drainage confirmed it. Hemothorax, significant volume. Grace Ellerman's O2 climbed back to 95, then 97. Her blood pressure, which had been trending down, stabilized. Patel looked at Claire. Nice catch. You got there, she said. I just said it faster. She was back in the corridor before he could answer. Voss arrived in the ED 40 minutes into the mass casualty response. He was not technically on trauma call. He was a surgical specialist, not an emergency surgeon. But Ridgecrest's trauma chief was currently in the middle of a scheduled surgery, and Voss had a way of appearing in major situations that had less to do with necessity and more to do with positioning. He arrived with two of his residents, assessed the overall situation with the sweep of a man who is accustomed to being the most capable person in any given room, and began directing the flow of surgical triage referrals. He found Claire in Bay 4, where she had moved after leaving Bay 7. Bay 4 was where the critical cases were being triaged, and the case in Bay 4 was a 29-year-old man named Daniel Pratt, who had been a passenger in one of the secondary vehicles. He had come in conscious but agitated, with obvious right-side arm trauma and a laceration above his left eye that had bled dramatically enough to create a genuinely alarming visual, but neither of which was what Claire was worried about. What she was worried about was the mechanism of injury: restrained driver's seat, high-speed rear impact, airbag deployment, and the way Daniel was breathing, not labored, not fast, almost too controlled, like a person whose body was working very hard to maintain something that was starting to slip. His skin was slightly pale at the lips. His hands were cold. She had just told the ED resident in Bay 4, a first-year named Kowalski, no relation to the surgical patient from 3 weeks earlier, that she wanted to rule out a cardiac contusion and possible aortic injury when Voss walked in. He took one look at the scene: the bleeding laceration, the broken arm, the agitated patient. He read the presentation the way it looked rather than the way it was. "Standard blunt trauma workup," he said to Kowalski. "Get ortho on the arm, get plastics on the lac." "I think we should rule out aortic injury," Claire said. Voss turned. He recognized her. The recognition was not warm. "Nurse Sutton," he said. "What are you doing in this bay?" "I was directed here by triage." Her voice was level. "Dr. Kowalski, the mechanism of injury with the deceleration impact at this speed," Dr. Kowalski, Voss said, "is going to follow the standard blunt trauma protocol, which does not include cardiac imaging based on a floor nurse's opinion. His distal pulses are asymmetric. Left radial is stronger than right. That pattern with this mechanism is not a diagnosis." Voss's voice was quiet, controlled, and completely certain. "You are a floor nurse, and you are not a physician. Your job right now is to do what you're assigned to do in this department and to let the doctors make the clinical decisions. That's not a suggestion." Daniel Pratt, on the gurney, was watching this exchange with the particular focus of a person who is trying to determine whether the people around him know what they're doing. "Can someone just," Daniel said, "can someone just tell me what's happening? Because my chest really hurts and I feel—" He didn't finish the sentence. His blood pressure tanked on the monitor in the space of about 4 seconds, systolic dropping from 118 to 79 to 61. And his color went from pale to gray, and his eyes went glassy in the way eyes go when the brain is no longer getting enough of what it needs. Kowalski reacted immediately. So did the nurses. Voss moved to the bedside with the controlled urgency of someone who knows what a crashing patient looks like. "Get me a crash cart, get anesthesia." "Aortic dissection," Claire said. Clear, flat, not a suggestion. "His BP is differentially lower on the right. The pain pattern is—" "I can see what's happening, Nurse Sutton. You need a T now, not in 5 minutes. If this is a type A dissection, get her out of this bay." Voss didn't yell it. He said it to the tech near the door with the calm specificity of a man who has decided something. "Get her out, and keep her out." The tech looked uncertain. Claire stood for a moment. She looked at Daniel Pratt, who was no longer really looking at anything. She looked at the monitor. She looked at Voss. And then she did something that looked, to everyone in that room, like backing down. She walked out of Bay 4 and went back into the corridor. But she didn't go far. She walked to the nursing station at the center of the ED, and she found Dom, the charge nurse who'd given her the vest, and she said, quiet and direct, "Bay 4. The patient is in hemorrhagic shock. I believe it's aortic. Type A dissection based on mechanism, presentation, and differential BP. I need you to get cardiothoracic surgery on the phone right now. Not in a minute. Right now." Dom looked at her. 4 seconds. "What's your basis?" he said. She told him in 40 words. Dom picked up the phone. The cardiothoracic fellow who answered the page arrived in Bay 4 6 minutes later and confirmed via the emergency TE that got ordered in the next 4 minutes after that, a type A aortic dissection. Daniel Pratt was in the OR within 22 minutes of the call. He survived. Voss knew by the time Daniel was being wheeled toward the elevator what the imaging had shown. He knew what it meant about what Claire had said. He stood in the corridor outside Bay 4 with one of his residents, and he didn't say anything for a long moment. Then he said, "Find out which unit she's assigned to." The resident nodded. It was not the response of a man who was preparing to apologize. The helicopter arrived at 6:47 in the evening. The mass casualty response had wound down. The last critical patient had been triaged. The OR was running 4 simultaneous cases, and the ED had settled into the elevated but sustainable pace of a department that has come through something hard and is now simply dealing with what remains. Claire was finishing a handoff note at the nursing station when the overhead page went out. Trauma activation, rooftop helipad, military medical transport, all trauma team to Bay 1. The hospital had a rooftop helipad, rarely used except for air transfers from rural facilities. Military transport was rarer still. Claire set down her pen. She didn't go to Bay 1 immediately. She had no reason to. She was a floor nurse, not trauma team. She finished the handoff note, checked in briefly on 2 of the patients she'd been managing during the mass casualty response, and then, because the pull was there and she wasn't quite ready to ignore it, walked toward the stairwell that connected the main floor to the elevator bank nearest the rooftop access. She could hear them before she could see anything. Boots on the corridor floor. Not the rubber soles of hospital staff, but something harder, more deliberate. And voices that had a particular quality she recognized in the way you recognize a sound from your own past that you'd convinced yourself you had moved far enough away from. She stopped walking. A gurney came through the corridor doors, pushed by 2 men in tactical gear. Not military dress uniform, something more operational, low profile. The patient on the gurney was a large man, mid-40s, fit in the way that military training sustains, with an oxygen mask over his face and field dressings on his left side that were the distinctive application of someone who knew what they were doing under pressure. IV lines in both arms. His vitals were being relayed by one of the men flanking the gurney to the trauma resident at the head of the team. Claire pressed herself to the side of the corridor as the gurney passed. The man on the gurney turned his head, and he looked directly at her. She had moved back far enough that she should have been just another hospital staff member. She was wearing her scrubs and her badge and her ponytail. She looked like everyone else in the corridor. But the man on the gurney stopped looking at the ceiling and looked at her, and in his eyes, glassy with pain, blurred with blood loss, there was a recognition that had nothing to do with this hospital or this corridor or this version of her life. His mouth moved. She couldn't hear it over the noise of the transport team, but she could read it. Morgan, the name she hadn't been called in 3 years. The gurney turned the corner toward Bay 1, and Claire Sutton stood in the corridor with her back against the wall, and for the first time in 4 months, her face did something it hadn't done once in all the warnings and humiliations and quiet battles of her time at this hospital. It went completely still, not calm. Still. The way a person goes still when something they thought was behind them suddenly appears directly in front of them, and there is no version of the next hour that doesn't require them to decide who they actually are. She didn't move for another 3 seconds. Then she pushed off the wall and walked in the opposite direction, back toward the MedSurg unit, because that was what she was supposed to do, and because she had spent 3 years building a life around doing exactly what she was supposed to do, and one man on a gurney reading her face in a corridor wasn't enough to undo that. Except that was a lie, and she knew it was a lie before she'd taken 10 steps. She stopped at the water fountain outside the elevator bank, bent down, drank, and stayed bent for a moment longer than necessary with the cold water running over her lip. Her pulse was elevated. Not from fear exactly, closer to the particular physiological response of a person who has trained their body to recognize threat, and whose body has just done exactly that and is now waiting for the brain to catch up with the decision. The man on the gurney was Marcus Hale. She hadn't seen him in 3 years, 2 months, and some number of days she had deliberately stopped counting. The last time she'd seen him, he had been standing on a tarmac in a location she was not going to think about in a hospital corridor, and he had been alive, and so had she, and both of those outcomes had required things that she did not talk about, and had not talked about since. He was on that gurney with field dressings on his left side, which meant abdominal or thoracic trauma, which meant something had gone wrong somewhere, which meant he needed... She straightened up and turned around. She wasn't going to Bay 1 as Major Claire Morgan. She was going as Nurse Claire Sutton, who had trauma experience and had been one of the better functioning people in the ED for the last 6 hours of a mass casualty event, and who had a completely legitimate professional reason to offer her hands. She told herself that twice on the way there. It didn't quite work, but it was functional enough. Bay 1 during a trauma activation had the controlled intensity of a place where everyone knows that speed and precision are the same thing. When Claire came through the corridor entrance, she could see through the glass panel that the trauma team was working. 3 nurses, 2 residents, an attending she recognized as Dr. Serena Falk, who was Ridgecrest's trauma fellow, and who was, in Claire's professional assessment, the most competent physician in the ED by a margin that the hospital probably didn't fully appreciate. What she couldn't see clearly was Voss, but she could hear him. His voice was coming through the glass, calm and directive, and the thing that settled in Claire's chest when she heard it was not quite dread. It was something more specific, the recognition of a person who is performing confidence rather than deploying it, and who in a different kind of situation, a situation with more witnesses and more visibility, was going to make a decision based on what looked right rather than what was right. She pushed through the door. Falk looked up. She'd worked alongside Claire 3 times in the last month, briefly enough that they weren't friends, but long enough that Falk had formed an opinion. "Sutton, you're still on? I can stay if you need hands." Falk nodded toward the supply station. "Glove up." Voss, at the head of the gurney, did not look up immediately. He was reviewing the field report that one of the tactical team members, they'd identified themselves only as Federal Medical Transport, no unit designation, had handed over. The other operator, a younger man with close-cropped hair and an expression that didn't move much, was standing near the wall, watching everything. Marcus Hale was conscious. That was the first thing Claire confirmed when she moved to the bedside. His eyes were open and tracking, which, given the blood loss evident in the field dressings, was a better sign than it might have been. His BP on the monitor read 88/60, which was not good. His O2 was at 93 on supplemental. "What's the mechanism?" she asked the operator near the wall, because the field report was with Voss and she needed information. The man looked at her. "Training accident. Crush component followed by blast over pressure at close range. He's got a left-sided hemothorax, possible splenic involvement. He was stable enough to transport, but he's been trending down for the last 40 minutes. Any LOC at scene?" "Briefly, about 90 seconds. He came back on his own." She was checking his pupils, equal, reactive, slightly sluggish, when Marcus Hale's eyes found hers. The focus that came into them was immediate, not the gradual orientation of someone coming out of shock. Instant. "Morgan," he said. His voice was rough and quiet. The oxygen mask muffled it enough that nobody else caught it. She kept her expression clinical. "Sir, I need you to stay still. We're going to take care of you." "Morgan," he said again, and this time there was something in it that was not just recognition. It was the specific register of a man who has been in enough bad situations to know when the situation has just become materially better. "Don't talk," she said. "Save it." Voss had looked up from the field report. He looked at Claire, and then at the patient, and then back at Claire, and whatever he'd intended to say about her presence in the bay got set aside because the monitor alarmed, BP dropping again, 81/54, and everything went to the immediate problem. "He's bleeding out faster than he was at transport," Falk said. "I want a fast exam now." The ultrasound was already at bedside. Claire moved to assist with positioning, and the fast exam took about 40 seconds and showed what it showed. Free fluid in the left upper quadrant. Significant. "Splenic laceration," Falk said. "He needs the OR." "Not yet." Voss set down the field report. "He's not stable enough for general anesthesia at this BP. We stabilize here, get him above 90 systolic, then we go." "If the spleen is actively bleeding," Falk started. "I know what the spleen does, Dr. Falk. We are not putting him under at 81 systolic. That's a death sentence." Falk pressed her mouth together. She wasn't wrong, and Voss wasn't entirely wrong, and the problem was that they were both right about different parts of an equation that wasn't going to hold for very long. Claire was hanging a second large-bore IV line, working fast because her hands knew how to work fast, and she was watching Marcus's face. He was doing what people do when they're trained, controlling their breathing, managing their pain response, staying present despite everything his body was doing. But she could see the effort in it. She could see the line he was walking. She had seen that line before. She knew exactly how close to the edge of it a person could get before they went over. We need TXA, she said. If we can reduce the coagulopathy while we're resuscitating, tranexamic acid has already been ordered, Voss said without looking at her. It was ordered 8 minutes ago. It should be here. She turned to the supply nurse. Where's the TXA? Pharmacy is, call them again. Nurse Sutton. Voss said it the way he said things when he wanted them to stop happening. You are here to assist. You are not here to direct this team. I'm not directing anyone. I'm asking where a medication is that should have been here 6 minutes ago. The supply nurse, caught between two people radiating different kinds of authority, made the call. The TXA arrived 4 minutes later. Marcus Hale's BP was 76/49 when it got pushed. What? The next 20 minutes were the kind of 20 minutes that don't feel like 20 minutes. They feel like a single sustained thing, one long breath held between the moment something goes wrong and the moment you find out whether it comes back. Falk ran the resuscitation with the kind of focused efficiency that Claire respected. Clean decisions, no grandstanding, constant reassessment. Voss contributed without undermining her, which was either professionalism or a temporary suspension of his usual operating mode brought on by the presence of people in that room. The two federal operators, still there, still watching, who didn't answer to hospital hierarchy. The younger operator had moved closer to the bedside at some point during the resuscitation. He hadn't said anything. He was just there, watching, with the particular quality of attention that meant he was tracking everything and filing it away. Marcus's BP climbed. Slowly, unsteadily, but it climbed. 84. 89. 91. Falk said, "Okay, he's going to hold long enough. Let's go." The push toward the elevator was fast. Claire helped with the gurney, and Marcus's hand, the right one, the one not connected to the primary IV, found her wrist as they moved. He didn't grab it. He just put his hand on her wrist for about 4 seconds, in the way of someone who wants to make contact before something uncertain. She let him. She didn't look at him. In the elevator, as the doors were closing, the younger operator stepped in alongside them. The doors closed. 4 people in a gurney in a space designed for 3. The operator looked at Claire. "You're the one who called for the TXA," he said. It wasn't a question. It was already ordered. "You're the one who made sure it actually showed up." Still not a question. She didn't answer. He pulled something from his jacket pocket, not a weapon, a phone, unlocked it, looked at something on the screen. Then he looked at her again with an expression that had shifted from neutral observation into something more deliberate. "What's your name, Lissette?" he said. "Claire Sutton. I'm a floor nurse on the med-surg unit." The elevator reached the surgical floor. The doors opened. The gurney went forward. Claire stepped back to let the surgical team take over their side of the handoff, which was her job and where her job ended. The operator stepped off the elevator and turned back to look at her as the doors began to close. He didn't say anything else. He didn't need to. The way he was looking at her said that he had either found something or confirmed something, and either way, the conversation they hadn't quite had yet was not over. The doors closed. She went back to med-surg. This is the part of the story that is hardest to explain to people who haven't lived a version of it. The way you can have something enormous happen and then go back to the ordinary mechanics of your life, as if the ground hasn't shifted, because the only alternative is to stand in the middle of the corridor and deal with it, and you don't have that option right now, and so you don't. Claire went back to med-surg. She checked on Walter Reyes, whose anticoagulation therapy was proceeding without incident, and who had stopped asking about the catheter and was now mostly irritated about the television remote. She updated 2 handoff notes. She helped a patient named Dolores, 78, recently post-op for a bowel resection, reposition in her bed, because Dolores had been slipping toward the left rail for the past hour, and the angle was bothering her back. "You're still here?" Dolores said. "What time is it?" "Little after 8. You've been here since morning?" "Since 6. Dolores looked at her with the particular scrutiny of an older woman who has decided she's earned the right to say what she's thinking. "You need to eat something." "I'll eat when I'm off." "You'll eat something now, or I'll call the nurse." "I am the nurse." "Then you'll call yourself." Dolores settled back against the repositioned pillow with the satisfied expression of someone who had won. "There's a granola bar in my bag. My daughter brought them, and I'm not supposed to eat them yet. Take one." Claire took the granola bar. She ate it in the corridor outside room 11, leaning against the wall, because Dolores was right, and the alternative was her hands starting to shake, which she couldn't afford. She was on the last third of it when her pager went off. It was an internal page from the nursing supervisor's office, not a patient emergency page, an administrative page. Her stomach did the things stomachs do when they already know. She finished the granola bar, folded the wrapper twice, put it in her pocket, and went to the nursing supervisor's office, which was on the ground floor near the administrative wing, and which she had been in once before, for her onboarding paperwork. The nursing supervisor was a woman named Patricia Owens, who was technically competent and administratively cautious, which in Claire's experience meant she would do what she was told by people above her and feel bad about it. Owens was behind her desk. Voss was not in the room. But the man who was in the room, standing near the window with his arms crossed and his expression set to a register Claire recognized as institutional self-protection, was the chief of medical staff, whose name was Dr. Curtis Main. Main. Claire, Owens said, "Sit down." She sat. Main began with the procedural language. Several reports had been received, concerns about nursing staff operating outside their designated scope in the emergency department, an ongoing pattern of behavioral issues documented across multiple incidents, the hospital's obligations with regard to chain of command and staff conduct. He said it all in the tone of a person reciting something rather than saying it, which meant it had been prepared before this meeting and the meeting was not a discussion. "We're placing you on administrative suspension, effective at the end of your current shift," Owen said, "pending a formal review." Claire looked at her. "The patient who came in by military transport tonight, Marcus Hale, is he in surgery?" Owens blinked. "That's not. I want to make sure the surgical team has the full clinical picture from the ED resuscitation. There were some timing issues with medication delivery that should be documented accurately." Main uncrossed his arms. "Ms. Sutton, I don't think you understand." "I understand completely." She looked at him directly. "I just want to make sure the patient is okay before we do this part." There was a pause. "He's in surgery," Owen said quietly. "Good." Claire folded her hands in her lap. "Okay, go ahead." Main went ahead. The suspension was formal, documented, effective immediately. They were actually pulling her badge at end of shift rather than letting her finish. She would be escorted from the building. There was the language about the review process, and her rights, and the union contact and all of it, and she listened to it the way you listen to something you're going to need to remember later. When he finished, she nodded and stood and said, "Can I check in on 2 of my patients before I go?" Owen said yes, because she felt bad, which Claire had anticipated. She checked on Walter Reyes, stable, sleeping, and on Dolores, who was also sleeping, the TV on low, volume almost nothing, a cooking competition show that Dolores always complained about and always watched. Claire stood in the doorway of Dolores's room for a moment. Then she went to the locker room, changed out of her scrubs, got her bag, had her badge deactivated at the security desk, and walked out of Ridgecrest Memorial Hospital into the Tucson night, which was warm and dry and smelled like the desert the way the desert smells when it's finally cooling down after a long, hot day. She sat in her car in the parking lot for a while without starting it. She was thinking about the operator in the elevator, the way he'd looked at his phone and then at her, the specific quality of that look. She was thinking about Marcus Hale on the gurney, saying her name, not the name on her badge, not the name on her nursing license, the other name. She was thinking about the fact that Marcus Hale was in surgery at this moment, and that she was in a parking lot, and that the distance between those two things was something she had chosen 3 years ago and had been maintaining ever since, and that it had required a very specific kind of daily effort that most people couldn't see because it looked from the outside like simply being a quiet person who showed up for work and didn't cause trouble. Her phone rang. Unknown number. Arizona area code, but not one she recognized. She looked at it for 2 rings. Then she answered it. The voice on the other end was not Marcus Hale. He was in surgery. It was not the operator from the elevator. It was a woman's voice, measured and precise, with the particular cadence of someone who is used to delivering information that matters. "Ms. Sutton," the voice said, "or would you prefer Major Morgan?" Claire closed her eyes. "I was wondering when this call was going to come," she said. "It's coming now," the woman said, "and I think you already know it means the quiet life you've been building is about to get a lot more complicated." The voice on the phone belonged to someone who knew how to wait. Claire didn't fill the silence. She'd learned a long time ago that the person who fills silence first is the person who needs something, and she wasn't sure yet what she needed, or whether need was even the right frame for whatever this was. "My name is Colonel Diane Rourke," the woman said. "I'm the liaison officer for the Joint Special Operations Medical Command. I've been aware of your location for approximately 6 weeks, Ms. Sutton, or Major Morgan. I'll use whichever you prefer." "Sutton," Claire said. That's the name on my license." "Sutton," Rourke said without inflection. "Captain Hale's transport team flagged your presence at Ridgecrest approximately 4 hours ago. I've been reviewing the situation since then. Captain Hale is Commander Hale. He was promoted 8 months ago. There have been some changes." A pause that had the quality of something being measured. "He's out of surgery. The spleen was partially resected. He's going to recover." Something in Claire's chest loosened slightly, which was information about herself she filed away without examining. "Good. He's been asking for you since he came out of anesthesia. That's not why I'm calling, but it's relevant context." "Then why are you calling?" "Because Dr. Harlan Voss filed a formal complaint against you 40 minutes ago that characterizes your conduct in the ED tonight as reckless and insubordinate. Because the Chief of Medical Staff at Ridgecrest has suspended you and is recommending termination. And because based on what Captain Hale's team observed and what I've reviewed in the ED documentation from tonight, those characterizations are inaccurate in ways that are going to matter." Claire looked out through the windshield at the parking lot. A car was pulling in, headlights sweeping across the concrete. Normal. Ordinary. "What do you want, Colonel?" "Right now? Nothing. I'm informing you of the situation. What happens next depends partly on what you want." Another pause. "You've been very careful, Major. 3 years is a long time to maintain a cover that wasn't formally sanctioned." "It wasn't a cover, it was just a life." "It was both," Rourke said, without unkindness. "Get some rest. Don't go anywhere. I'll be in contact tomorrow morning." The call ended. Claire sat in the parking lot for another 10 minutes. Then she drove to the apartment she'd been renting for 4 months. 2 bedrooms, one of which she used as a bedroom, and one of which held a hospital-grade adjustable bed and a medical equipment cabinet and a baby monitor on a shelf. And she parked, and she went inside, and she checked on her father. Robert Morgan was 67 years old and had been living with a progressive neurological condition for 3 years, which was, not coincidentally, exactly as long as Claire had been building a quiet life in a series of mid-sized cities under a name that was hers, but wasn't the one she'd made her reputation under. He was asleep when she came in, the monitor light green, his breathing regular. She stood in the doorway for a moment the way she always did, not checking, exactly, more like confirming, and then she went to the kitchen and made herself eat something real, because the granola bar from Dolores was 4 hours ago and her body was running on fumes and adrenaline, and she'd learned the hard way that those 2 things eventually collected their debts. She sat at the kitchen table and ate leftover rice and looked at nothing in particular and thought about the fact that Marcus Hale had said her name in a hospital corridor and that a colonel she'd never met had known her location for 6 weeks, and that Harlan Voss had filed a complaint that was going to make the next several days genuinely complicated. She thought about Daniel Pratt, who had made it to the OR because Dom had made the call. She thought about Grace Ellerman and the hemothorax, and Walter Reyes and his left calf, and Sandra Kowalski, whose surgery had been delayed by 2 hours because Voss had thrown a chart across a counter, rather than consider that a floor nurse might have caught something he'd missed. She thought about the gap between what had happened tonight and what would be in the documentation, and how those 2 things were frequently not the same thing in institutions that had more interest in managing liability than establishing truth. Then she went to bed because tomorrow was going to require her to be functional, and functional was a choice she had to actively make. She was up at 5:30. Her father woke at 6, the way he always did, and she got him through the morning routine, medication, positioning, the 40-minute process of breakfast, that is, swallowing difficulties made slow and required patience. She had in genuine supply rather than performed supply, which was one of the things about caregiving that people didn't understand from the outside. It was either real or it wasn't. You couldn't fake it past the first month. Rourke called at 7:42. "I need you at Ridgecrest at 9, she said. "Not as a nurse, as yourself. I need to arrange care for my father first." A brief pause. "How long do you need?" "An hour. I have a neighbor who covers when I work nights. I'll call her." 9:30 then," Claire called Mrs. Papadakis, who was 73 and had been watching Robert 2 mornings a week since Claire had moved in, and who asked no questions about the changed schedule because she had learned over 4 months that Claire didn't explain things she didn't need to explain, and that this was not rudeness but something more structural. Mrs. Papadakis said she'd be there by 8:15. Claire put on those clothes she wore when she was not trying to look like anything in particular. Dark slacks, a plain gray shirt, the kind of flat shoes that worked for standing on hard floors for long periods, and she drove to Ridgecrest Memorial. The woman waiting for her in the hospital's main conference room was not what Claire had constructed from the phone call. Colonel Diane Rourke was 53, compact, with close-cropped silver hair and the posture of someone who had stopped performing military bearing years ago because it had simply become how she existed. She was in civilian clothes, a dark blazer, gray slacks, and she had a laptop open and a legal pad and 2 cups of coffee, one of which she pushed across the table when Claire sat down. Also in the room, the operator from the elevator, whose name turned out to be Sergeant First Class Leon Briggs, and who in daylight looked younger than he had the night before, maybe 32, with the particular combination of watchful eyes and deliberate stillness that Claire associated with a specific type of training. And standing near the window with his arms crossed in the posture of a man who had not been invited to this meeting but was present anyway, Dr. Curtis Main. Claire looked at Main, then at Rourke. "He's here as a courtesy," Rourke said. "He asked to be present." "I have significant concerns about the manner in which this meeting was arranged," Main said. "The hospital has its own—" "Dr. Main," Rourke said it the way you say something when you have already decided what the shape of the next hour looks like, and are extending a professional courtesy by informing the other parties. "You're welcome to stay. I'd recommend listening more than speaking." Main pressed his mouth closed. He stayed. Rourke opened the laptop and turned it to face Claire. On the screen was a document, a summary page with a classification header that Claire hadn't seen in 3 years, which was the particular blue and gray formatting of a Joint Special Operations Command personnel file. "For the record," Rourke said, "and for Dr. Main's benefit, this is the service record of Major Claire Morgan, United States Army Medical Corps. She served for 14 years, including 3 tours in high-intensity combat environments, 2 of which were in an attached capacity with Special Operations units. She received the Bronze Star with Valor device for actions in the field following an ambush that resulted in 4 KIA and 11 wounded, 8 of whom survived due directly to her field interventions. She was additionally cited for 2 separate incidents in which her medical decisions under fire were credited with preventing what the after-action reports described as, and I'm quoting, certain fatalities under conditions that exceeded standard trauma management parameters." Main had uncrossed his arms somewhere in the middle of that. "She separated from active service 3 years ago," Rourke continued, "on a medical hold that was subsequently cleared, following a situation that I am not going to discuss in detail in this room because the details are still classified. She has been working as a civilian nurse since then under her legal name, which is Claire Sutton Morgan. She goes by Claire Sutton. The nursing license is real, the training is real, and the 12 years of experience she listed on her application is, if anything, an understatement." Main looked at Claire. It was a different kind of looking than she was used to from administrators. "Last night," Rourke said, clicking to the next section of the document, "Sergeant Briggs and his team transported Captain Marcus Hale to this facility following a training accident that resulted in abdominal trauma and a hemothorax. The clinical documentation from the ED resuscitation, which I have reviewed in full, shows a pattern of accurate, timely, and in at least 2 instances critical clinical decisions made by Major Morgan in her capacity as the assisting nurse. The TXA call, the differential BP assessment in the earlier case, the one involving the aortic dissection, and the chest tube recommendation in Bay 7. The aortic dissection case was handled by the ED team," Main said. "It was handled by the ED team after Ms. Sutton bypassed the senior surgeon who had dismissed her assessment and went directly to the charge nurse with a clinical summary that got cardiothoracic on the phone 6 minutes before the patient's vitals crashed." Rourke said it without emphasis, which made it land harder than emphasis would have. "I've read the charge nurse's statement. I've read the CT fellow's statement. I've read the ED documentation." Silence. "Dr. Voss filed a formal complaint against her at 11:47 last night," Rourke said. "I'm here to discuss what happens to that complaint." "What happened to the complaint was this. It got complicated. Voss arrived at 9:55, 25 minutes into the meeting, and Claire watched him walk into the conference room and process what he was seeing. The laptop with its classification header, the woman in the blazer who had a quality of authority that didn't come from hospital hierarchy, the soldier near the window. And she watched him make the calculation that he had walked into something that was not what he had expected. And she watched him choose not to change his expression, which was its own kind of tell. "I was told there was a meeting regarding the nursing staff complaint," he said. "Sit down, Dr. Voss," Rourke said. He sat, slowly. Rourke went through it again. Less of the military record this time, more of the specific incidents. The Kowalski chart, the Reyes DVT, the aortic dissection, Bay 7, the TXA. She had documentation for all of it, which meant she had been thorough in a short period of time, which meant someone had been helping her compile it, which meant Briggs had been doing more than standing near walls and watching. Voss listened. When Rourke finished, he said, "With respect, Colonel, I don't know what the military's interest is in a nursing conduct matter at a civilian hospital." "Captain Hale is my interest," Rourke said, "and the conduct matter cuts in the other direction from how you filed it." "I filed an accurate account of—" "You filed an account," Rourke said. "Whether it's accurate is what we're here to determine." She turned the laptop to face him. It was no longer showing the service record. It was showing the ED documentation, time-stamped, specific, cross-referenced. "The aortic dissection patient. Walk me through your decision to dismiss the nursing assessment and proceed without cardiac imaging." Voss looked at the document. "I made a clinical judgment based on the presenting symptoms. The nursing observation was correct," Claire said. It was the first time she'd spoken since the meeting started, other than to confirm her name for Rourke's record. She hadn't planned to speak, but it was there, and it was true, and she was tired, not in the acute sense, but in the 3-year sense, and the tiredness had a way of burning off the careful management of what she said and didn't say. Voss looked at her. "The presenting symptoms you described as standard blunt trauma were atypical," she said. "The differential in the distal pulses was there on initial assessment. The mechanism was consistent with aortic injury. I told you that, and you removed me from the bay, and the patient nearly died in the window between when I was removed and when cardiothoracic arrived." She looked at him steadily. "I'm not trying to make this personal. I'm telling you what happened." "What happened," Voss said, with a precision that was close to contempt, "is that a floor nurse repeatedly exceeded her scope of practice, disrupted multiple clinical teams, and created a pattern of conduct that caught 3 things that could have killed patients," Briggs said from near the window. Quiet. Factual. Voss turned to look at him. Briggs looked back with an expression that had no particular hostility in it, which was somehow more effective than hostility would have been. The meeting went on for another 40 minutes. It did not resolve cleanly. Institutional situations involving liability and personnel records and federal personnel never resolved cleanly. They resolved through a process of documentation and counter-documentation and bureaucratic pressure that moved slowly and with considerable friction. But what happened in that room shifted the shape of what the next few days would look like, and Claire could feel it happening even in real time, the way weather changes. Not the storm itself, but the pressure drop that precedes it. At the end of the meeting, Maine said he would put the suspension on hold pending the formal review. Voss said nothing when he left the room. Rourke walked Claire to the corridor afterward and said, "Hale wants to see you. He's in the ICU. Room 4. "I know where the ICU is." "I know you do." Rourke looked at her with an expression that was not quite sympathy and not quite assessment, something in between. "You did something hard last night. Twice, actually. The clinical thing and the other thing." "I did my job." "The first thing, yes. The second thing, going back into that bay after he removed you, going to Dom instead of just leaving it, that wasn't the job. That was a choice." Rourke paused. "I want you to know it's been noted." Claire didn't know what to do with that, so she nodded and walked toward the ICU. Marcus Hale looked better than he had any right to look 12 hours after a partial splenectomy. He was sitting up at about 30 degrees. The nurses had gotten him there, the post-op protocol pushing early mobility, even in the ICU when vitals allowed. And he had the particular alertness of someone who has come back from a significant blood loss, and whose body is compensating with the biochemical intensity of a system that knows it almost lost. He had IVs in both arms. He was pale under his natural coloring. He had about a day's worth of stubble, and someone had given him a cup of ice chips that sat on the tray table and were mostly ignored. He looked at Claire when she came through the door, and something in his face did the same thing it had done the night before. That immediate, specific focus. "You look exactly the same," he said. "You look like you got hit by something," she said. "I did, sort of. Training accident. I'm not supposed to go into details." "I know. I read the field report." He almost smiled. It didn't quite make it all the way, but the intention was there. "How long have you been here? At this hospital?" 4 months. Tucson. Tucson. He looked at her for a moment. "And before Tucson?" "Albuquerque. Before that, El Paso." She sat down in the chair next to the bed because standing next to a bed in an ICU had a clinical quality that felt wrong for whatever this was. "I move every 8 to 12 months. Because of your father." "Partly. He needs different facilities at different stages. Partly because—" She stopped, started again differently. "Partly because it's easier." Marcus nodded. Understood what easier meant in that context without needing it explained, because he had spent enough years doing the math between what was easier and what was true, and understanding that those two things were sometimes the same calculation. "The kid with the aortic dissection," he said. "Briggs told me. He made it. Because of you. Because the CT fellow got there in time." "Claire." His voice was quiet and direct, and it was the voice she remembered from situations where there was no time for the softened version of anything. "I've read enough field reports to know the difference between a team outcome and a specific outcome. Stop doing that." She looked at the ice chips on the tray table. "I'm out of practice at people knowing what I did." "I know. That's been the problem." He shifted slightly and his face registered the shift. A quick tightening that he controlled but didn't quite suppress. 3 days out from a partial splenectomy would be that way. "The Colonel, Rourke. She's good. She knows who I am. She's known for a while, I didn't tell her." He paused. "For the record." "I know, she said 6 weeks. You've been in a training facility for the last 2 months." He looked at her. "You've been tracking." "I still have contacts." She said it simply, without apology. "Old habits." "How's your father?" "Declining, slowly. He's got good days." She looked at her hands. "He doesn't always know me, but he knows someone is there and he's not in pain, and that's—" She stopped. "That's what I've got right now." Marcus was quiet for a moment. It was the quality of quiet that people get when they're holding something back, not because they're concealing it, but because they're deciding whether the time is right for it. "Voss filed on you," he said. "I know." "Rourke is going to push back on it. Briggs documented everything from the ED last night. He does that automatically. It's his training. We've got timestamps and clinical observations that are going to contradict about half of what Voss put in that complaint." "I know that too." "So you know you're not going to lose this quietly." She looked at him. "I was never going to lose this quietly. That's been the problem since the first week." She leaned back in the chair. "I wasn't built for quiet. I've been trying to do it anyway because it was the option that kept my father safe and kept me in one place long enough to actually care for him properly. And it mostly worked. Until last night. Until you." He had the grace not to apologize. She would have found it irritating if he had. "What happens now?" he said. "Rourke talks to Maine. There's a formal review. Voss's complaint gets evaluated against the documentation. Probably takes 2 weeks, possibly longer. Depending on how it goes." She stopped. "Depending on how it goes what?" She shook her head slightly. Not an evasion, more like she was working the problem in real time and hadn't gotten to the end of it yet. "I don't know. I haven't had to think past 4 months at a stretch for 3 years. It's a different kind of thinking." The door to the ICU room opened and a nurse came in to do a vitals check. Not Claire's unit, a woman she didn't know, young and efficient, who took Marcus's pressure and checked the IV lines and made 2 documentation entries on the tablet and left without having fully registered that Claire was there at all. After she left, Marcus said, "The guys want to see you." Claire looked at him. "The team. 4 of them flew in this morning when they heard about the transport. They're in the family waiting area down the corridor. They've been there since 6 a.m. He watched her. They know you're here. Briggs told them. Marcus, I know, he said. I know you built something here. I know it's not what you had before, and I know that was intentional. I'm not asking you to go back to what you were. He looked at her with the directness of someone who has had enough close calls to have stopped managing things from a distance. I'm asking you to let people who know who you actually are say so, out loud, in a place where it matters right now. She stood up. She walked to the window and stood with her back to him for a moment, which was not avoidance but a way of dealing with the fact that her face was doing something she didn't fully control, and she didn't want to manage it in front of him, not because he wouldn't understand, but because she needed a moment where she wasn't being seen. The view from the ICU window was the hospital's east courtyard, a square of struggling grass and a concrete path and a single mesquite tree that had somehow survived in a gap between the building and the parking structure. Someone had put a bench there. Nobody was sitting on it. She turned around. Tell them I'll come by, she said. Marcus nodded. She picked up her bag. She was almost at the door when he said, Morgan. She stopped. The name, her name, the one she'd set down 3 years ago like something too heavy to keep carrying, landed differently in an ICU room at 9 in the morning than it had in a corridor the night before. Whatever they decide about your position here, he said, you didn't do anything wrong. She looked back at him. I know, she said. That's the part that was always going to be the problem. She walked out into the corridor. The family waiting area was 30 feet to her left. She could see through the glass panel. 4 men in civilian clothes sitting in the hospital's vinyl chairs with the particular posture of people whose bodies are trained for more active positions and are tolerating the chairs as a temporary condition. One of them was looking at his phone. One was looking at the door. The one looking at the door saw her first. He stood up, and then the others did. And through the glass, she watched 4 men who had last seen her in a context she had spent 3 years not thinking about stand up in a hospital waiting room because she had come into the corridor. Her chest did something complicated. She pushed through the waiting room door. The man nearest the door was tall, red-haired, with a scar along his jawline that had been newer and more dramatic the last time she'd seen it. His name was Sergeant Todd Warwick, and he had been the operator she'd performed an emergency surgical airway on in the field, on her knees in rubble, with a headlamp and instruments from a kit that had already been damaged, and he had lived and was currently looking at her with an expression that was somewhere between careful and something she didn't have a word for. Major, he said, I'm not a major right now. Ma'am. He didn't say it correctively. He said it the way soldiers say it when they mean something that doesn't have a simpler word. We heard about last night, all of it. You heard fast. Briggs texts, said the one with the phone, from the back of the group, without looking up. Warwick said, we just wanted... He stopped, restarted. We've got a lot of things we've wanted to say for 3 years. We didn't know where you were. And then we did know where you were, and Hale told us to let you be. He glanced back at the ICU corridor. He was right, but we're here now. She looked at the 4 of them. They were older than she remembered. They all were. That's what 3 years did. You should have let me be, she said, and then, because it was true in a way that complicated the first statement, I'm glad you didn't. The one in the back finally put his phone down. The one next to Warwick, younger, with the still healing look of someone who'd been in the field recently, shifted his weight and said something that she almost didn't catch, half under his breath. We told Command you were the best trauma medic we'd worked with, he said. We put it in 3 separate after-action reports. She looked at him. Nobody pulled your file, he said, until last night. The waiting room was quiet. Through the window, the mesquite tree in the courtyard moved slightly in a morning wind she couldn't feel from inside the building. She was still standing in the doorway. She made herself step fully into the room, which was a smaller physical act than it sounds and a larger one than it looked. And she sat down in one of the vinyl chairs that was terrible for anyone's back. And the 4 men around her settled back into their seats. And the conversation that followed was not about the hospital or Voss or the complaint or Rourke. It was about people they'd known, updates on where people had ended up, a few stories she hadn't heard, one that she had from a different angle. Normal, the way things are normal after a long absence. Bumpy and warm and slightly too loud and nothing like enough. She had been there about 20 minutes when her phone buzzed. A text, local number she didn't recognize. "This is Patricia Owens. Dr. Voss has called an emergency meeting with the department heads for this afternoon. He is presenting his complaint formally. I thought you should know." She looked at the text for a moment. Then she looked up at Warwick. "I need to make a call," she said. "We'll be here," he said. She stepped out into the corridor and called Rourke. Rourke picked up on the second ring. "Voss is moving fast," Claire said. "I know. I just got the same information. He's going to make this a formal departmental action before the review process can run. If he gets in front of the department heads today with his version, I know what he's doing." Rourke's voice was controlled but not relaxed. "Are you still in the building?" "Yes." "Stay there. Don't go anywhere near that meeting. I'm making a call." "To who?" A pause that felt like a person choosing how much to say. "The kind of call," Rourke said carefully, "that Dr. Voss is not going to be prepared for." The corridor outside the ICU was quiet. Down at the far end, near the elevator bank, a gurney was being wheeled past. Normal hospital morning. Nobody hurrying, nobody in crisis. Claire looked at the ICU door behind which Marcus Hale was recovering from surgery. She looked at the waiting room where 4 men were sitting in vinyl chairs. She looked at the text from Owens on her phone. And then, for the first time in 4 months, possibly for the first time in 3 years, she let herself think past the next 4 months. She didn't get far. The thinking was rusty, and she was running on 5 hours of sleep, and the situation was still actively in motion. But she got far enough to know that what was coming this afternoon was not going to be another incident that got documented and filed and silently absorbed. Whatever Voss was walking into that meeting with, he was about to walk into something he hadn't put in his complaint. Her phone buzzed again. Same number. "Owens. He's also requesting your personnel file from HR." Claire read it twice. Then she went back into the waiting room, sat down in the bad chair, and said to Warwick, "Tell me about the last 6 months." He looked at her. "I need 45 minutes where I'm not thinking about this," she said, "and then I'm going to need your help with something." Warwick looked at the man with the phone, who looked at the younger one, who looked back at Warwick. Some kind of short-circuit communication that she recognized from years of watching teams operate. "Done," Warwick said. "What do you need?" What Warwick gave her in those 45 minutes was not a briefing and not quite a debrief. It was something in between. The kind of information transfer that happens between people who have operated in the same environments and don't need to frame things for each other, who can say a name or a location in 2 words, and have the other person understand the full shape of what that represents. She learned that the team had rotated through 2 additional deployments in the last 3 years, both in advisory capacities. She learned that 2 people she'd known had separated from service, one with a medical discharge, one voluntary. She learned that the training accident that had put Marcus Hale on a gurney was more complicated than a training accident, which was all Warwick said about it, and all she needed to hear to understand the category it fell into. In return, she told them about her father, about the progression of his condition, about the 3 cities in 3 years, and the specific calculus of finding facilities that could handle his needs in neighborhoods where a single woman with a parent in home care didn't raise questions and units short-staffed enough to hire without excessive background scrutiny. The younger operator, whose name was Kellerman, she'd learned, 28, from somewhere in Ohio, listened to all of it with the focused attention of someone who was building a picture. When she finished, he said, "You've been running this completely alone?" "I have a neighbor who helps mornings. I mean the other part, He gestured vaguely at the air, which she understood to mean the institutional navigation, the identity management, the daily effort of being one person in a context that knew nothing about the other person. "All of it." "Yes." He nodded slowly, the way someone nods when they're revising an estimate upward. She recognized it. She'd done it herself, looking at situations in the field that were harder than they'd looked from the outside. When her phone buzzed with the text from Owens, and she told them she needed their help, what followed was not a dramatic strategy session. It was 4 men and 1 woman in a hospital waiting room with bad coffee and worse chairs, working a problem with the lateral efficiency of people who were trained to work problems in whatever environment they were placed in, which happened right now to involve vinyl flooring and a vending machine instead of anything more operationally appropriate. What she needed was documentation. Not new documentations, existing documentation, assembled and presented in a form that a room full of department heads could absorb in the window, between when Voss started speaking and when the weight of what was actually true made his version of events untenable. Briggs had timestamps. Briggs had everything, it turned out. He had been running his field documentation protocol in the ED the night before the way he ran it everywhere, because it was how he was trained and because he didn't turn it off. And what he had was a contemporaneous log of everything Claire had said, done, recommended, and been dismissed for in Bay 4 and Bay 7, cross-referenced against the ED monitor data that was independently timestamped by the hospital's own systems. The aortic dissection case had a window. Between when Claire told Voss about the differential BP assessment and when Voss removed her from the bay and when Dom made the cardiothoracic call, that window was documented to the minute. Daniel Pratt's monitor data was in the hospital's system, independently, and it told its own story about what had been happening to him during that window. Rourke was already pulling it. What Claire could do, what she did, in the 40 minutes before she needed to be back in the building with any kind of standing, was write out a clear clinical narrative of each incident, not a complaint, not a counteraccusation, a clinical narrative, factual, time-stamped, with the medical reasoning explicit and the outcomes stated plainly. She wrote it on her phone, in the Notes app, because that was what she had. Kellerman took it and typed it properly on his laptop, formatted it, sent it to Rourke's email. The man with the phone, whose name was Specialist Adeyemi, and who turned out to have a background in intelligence analysis before he'd moved into special operations, pulled the publicly available licensing records for Voss and cross-referenced them against the Arizona Medical Board's public complaint registry, because that was public information and it took him 11 minutes. There were 2 prior complaints against Voss on record, both closed without action, both filed by nurses. She looked at that information for a moment. "It's a pattern," Adeyemi said. "It's 2 data points," she said. "Pattern needs 3. "Sandra Kowalski," Warwick said. She looked at him. "You told us about her, the chart, the timing adjustment, the surgery delay." He was matter of fact. "That's the 3rd data point. You documented your adjustment and he overrode it, and then the cardiac team independently confirmed you were right and the surgery got delayed. All of that is in the hospital record." She sat with that for a moment. 3 incidents. 3 times a nurse had flagged something. 3 times Voss had dismissed it. 2 prior complaints, both from nurses, both closed. The pattern didn't prove anything by itself. Patterns in medicine were complicated. Institutions were complicated. And she understood better than most people how easily a capable surgeon could generate institutional goodwill that buffered against accountability. But it was no longer just her word against his. She sent a second message to Rourke with the complaint registry information and the Kowalski documentation reference. Rourke responded in 4 minutes. "Already have it. Stay available." The department heads meeting was scheduled for 2 o'clock in the hospital's main conference room, the same room where Rourke's meeting had taken place that morning, which had a quality of coincidence that Claire doubted was coincidental. Rourke had requested access. Maine had, after what was presumably a difficult conversation, agreed. Claire arrived at 1:45. She was not invited to the meeting. She was not presenting anything. She sat in the corridor outside the conference room on a chair that was marginally better than the ICU waiting room chairs, and she waited, which was its own form of difficult. Voss arrived at 1:52. He saw her in the corridor and his pace did not change, but something in his expression registered and resolved before he pushed through the conference room door. Rourke arrived at 1:57 with Briggs and a woman Claire hadn't met. Late 40s, civilian clothes, carrying a leather document folio that had a particular quality of officiousness that Claire associated with legal counsel. Rourke paused at the door. "You're going to hear most of this," she said to Claire. "The door doesn't seal well." "I know," Claire said. "I've been in this corridor before." Rourke went in. What followed was 2 hours and 20 minutes of a meeting that Claire heard in the way you hear things through an imperfectly sealed conference room door, clearly enough to follow, with gaps and muffled sections that required inference. She didn't try to fill in everything. She listened to what she could hear and let the rest be. She heard Voss's presentation, which was confident and structured, and made a coherent case for a nurse who had repeatedly exceeded her scope, disrupted clinical teams, and created liability exposure for the hospital. I was good at it. She had to give him that. He had the language of institutional self-protection completely mastered, and he used it in the way of a person who has been using it for long enough that it had become natural. She heard Rourke's response, which was methodical and specific, and went incident by incident through the clinical documentation. She heard the point at which Rourke introduced the Briggs log. She could tell because the quality of the sound in the room changed, the way a room changes when something enters it that people weren't expecting. She heard Maine's voice, asking a question she couldn't fully make out. She heard the word Kowalski, and then a longer exchange that she couldn't follow. She heard someone else, not Rourke, not Voss, not Maine, a voice she didn't recognize, say clearly enough to parse, "The cardiothoracic fellow's report says the nursing assessment was accurate and that the delay in acting on it," and then the door at the far end of the corridor opened and a family of 4 walked through it with a balloon, and the noise covered the rest of the sentence. She sat with her hands in her lap and her back against the wall, and she did not think about what she couldn't control. She thought about her father, who would need his afternoon medication at 4:30, and for whom Mrs. Papadakis had a 4 o'clock limit. She thought about Walter Reyes, who was presumably being discharged today or tomorrow, and who had asked her 3 days ago if there was anything he could bring her as a thank you, and to whom she had said no, which was true, and also not entirely what she'd felt. She thought about Dolores and the granola bar and the cooking competition show, and whether Dolores had been discharged yet, and whether her daughter had come. She thought about Marcus Hale in the ICU, getting his first post-surgical physiotherapy visit today, which was going to be uncomfortable and necessary, and which he would handle with the particular stubbornness of people who have been trained to push through things that most people would stop for. At 4:17, the conference room door opened. The woman with the legal folio came out first, said something into her phone, and walked down the corridor without looking at Claire. Then 2 of the department heads Claire didn't know well, the head of cardiology and the director of nursing, came out in conversation with each other. The director of nursing, a woman named Sheila Graves, who Claire had met once during her onboarding, looked at Claire when she passed. The look was not hostile. It was complex in a way that Claire didn't have time to fully read before Graves had walked on. Then Rourke. Rourke came through the door and looked at Claire and said, "Come with me." They walked to a small office down the hall, an empty one, clearly borrowed, and Rourke closed the door and said, without preamble, "Voss's complaint has been formally referred for investigation by the hospital's Quality Assurance Committee. That's separate from his complaint against you. It encompasses the Kowalski incident, the Pratt incident, and 3 additional cases that the QA committee pulled when they reviewed his file against our documentation." She paused. "The prior nursing complaints, the ones on the medical board registry, have been requested for review as part of the same file." Claire sat down in the chair on the near side of the desk. "That's a significant action." "It is. It's not a termination and it's not a license suspension, both of which take longer and require more process. But it's a formal investigation, and the hospital's liability insurer has been notified, which changes the institutional calculus considerably." Rourke sat down across from her. "Your suspension has been formally lifted. The complaint against you has been reclassified as pending the QA investigation outcome, which in practice means it's on hold indefinitely." Claire nodded. "You can return to work tomorrow if you choose to," Rourke said. "That decision is yours." "Is Voss still practicing?" "He's been placed on a temporary modification of his surgical privileges, supervised cases only, pending investigation. The hospital's legal counsel recommended it as a liability management measure." Rourke said it without satisfaction, which was the correct register for what it was. It wasn't a victory. It was a beginning of a process that might or might not result in full accountability, which was how institutions worked when they were working correctly, which they didn't always do. "That's appropriate," Claire said. "Yes," Rourke looked at her. "How are you?" The question caught her slightly off guard. Not because it was unexpected from a human standpoint, but because the meeting had been so procedurally structured that the shift into the personal register required a small recalibration. "I'm fine," she said, which was partially true. "Your father?" "He's covered until 6. I need to be back before then." Rourke nodded. "I want to be direct with you about something. The military's interest in this situation, in your situation, doesn't end with Hale's recovery. There's been a conversation at a command level about what happens to people with your background and your skill set when they leave the active structure and end up in civilian institutions." She chose her next words carefully. "You're not the only one, but you might be the most visible example right now of what it looks like when the institutional context doesn't know what it has." Claire looked at the wall for a moment. That's a diplomatic framing. It's an accurate one. The institutional context knew exactly what it had, Claire said. It just didn't care, because what it had was a floor nurse who kept making the surgeons look like they'd missed things. That's not a knowledge problem. That's a structural problem. Rourke considered that. Yes, she said. That's a more accurate framing. She was in the parking lot, keys in her hand, when Voss found her. She heard him before she saw him. Not his voice, but his footsteps. The particular quick stride of someone who has decided something and is moving before the decision can be questioned. She turned around before he spoke, which she could see surprised him. He looked different from this morning. Not diminished. Voss was not the kind of man who diminished easily, but changed in the way a structure changes when something load-bearing shifts. He was still immaculate, still certain in his posture, but there was something in his eyes that had moved from contempt into something more complicated. I want to say something, he said. She waited. What you did last night with Pratt, he stopped, started differently. I've been a surgeon for 22 years. I have looked at hundreds of blunt trauma presentations. The differential I saw was consistent with standard findings. My clinical judgment was, you were wrong, she said, not unkindly, flatly. His jaw moved. I am aware of that. And you removed me from the bay while you were wrong, and then the patient's pressure dropped, and then the cardiothoracic team confirmed what I'd said. She looked at him. That's the sequence. The documentation reflects the sequence. I know what the documentation reflects. He said it with the controlled frustration of a man who is accustomed to being the one who writes the documentation. I want to understand how you knew. The presentation wasn't... The mechanism was specific, and the differential was subtle. And I've seen it before, she said, in conditions where missing it meant someone died. You learn fast in those conditions, or you don't learn at all. She met his eyes. That's the whole answer. He looked at her for a long moment. She could see him processing something, not what she'd said, which he'd understood, but what it meant in the framework of how he had categorized her, which was something she could actually watch him revise in real time, which was not something she had expected to see from him. The complaint, he said, is being investigated, along with some other things. She kept her voice neutral. That process is going to run. I can't speak to where it ends up. He nodded, once, slowly. Then, the patient, Pratt. He's going to recover? He's in post-op ICU. The surgical repair was successful. He should recover fully. Voss nodded again. She watched him do the thing people do when they are holding the specific knowledge of how close something came to going the other way, and what that would have meant, and who they would have been in that version of events. He didn't apologize. She hadn't expected him to. Apology required a restructuring of self-understanding that didn't happen in a parking lot the day after. Maybe it happened later, maybe it didn't happen at all. Either way, it was his to work out. What he did was nod and turn and walked back toward the hospital entrance. She watched him go. Then she drove to pick up her father's afternoon medication from the pharmacy 2 miles away, because that was what needed to happen next. The following 4 days were the institutional equivalent of a weather system moving through, disruptive, occasionally dramatic in specific moments, and mostly experienced as a sustained pressure that required navigation rather than any single confrontational event. The QA investigation opened formally on Thursday. Claire received written notification that her suspension was rescinded and her personnel file had been updated to reflect the reclassification of the complaint. She returned to work Thursday morning on the day shift, which Owens had assigned her to, possibly deliberately, possibly as logistics, and which meant she was on the floor when the news about the investigation had already circulated through the unit. She had expected the atmosphere to be uncomfortable. It was, but differently than she'd anticipated. The discomfort was not hostility. It was the particular social awkwardness of people who have positioned themselves in a certain way relative to a situation and are now recalibrating. Barry, the charge nurse, gave her the morning patient assignments with an efficiency that was slightly more careful than usual, which was his way of acknowledging something without saying it. Tasha appeared at her elbow around 10 a.m. during a documentation moment and said, I heard Voss is on supervised privileges, with a carefully neutral expression that didn't quite conceal the fact that this information had made her mourning. It's an investigation, Claire said. Let it run. I know, Tasha said. I'm just saying. Walter Reyes was discharged Thursday afternoon. Claire was in the corridor when his transport came, and he saw her and waved with the arm that wasn't attached to anything anymore, and called out, "You!" with the pointing gesture of a man who has something to say to a specific person. She walked over. His daughter was with him, a woman in her 40s named Patricia, who had the tired but relieved look of someone who had been anxious for several days and had only recently been allowed to stop being anxious. "My daughter tells me you're the one who called for the scan," Walter said. "The attending ordered the scan. You called for it." I flagged a concern, yes. He looked at her. He was 71 and had been through a hip replacement and a DVT scare in 4 days, and he looked exactly like what that experience produced. Tired and slightly frail and completely clear-eyed. "Thank you," he said. "You're welcome, Mr. Reyes." "Walter." "Walter," she said. Patricia grabbed her hand and held it for a moment without saying anything, which was more than most people said with words, and then the transport aide wheeled Walter toward the exit, and they were gone. She stood in the corridor for a moment. Tasha, passing with a medication cart, said, "You okay?" "Yes," Claire said, which was true in a different way than it had been 4 days ago. On Friday, Rourke called. "The command review has concluded," she said. "Captain Hale was able to participate via video. He's recovering well, incidentally. They're moving him to step down tomorrow." "I know, I saw him yesterday." A brief pause. "I didn't know that." "He paged me." She had gone to the ICU during her lunch break, which was technically fine since she was a hospital employee, and the ICU was not outside the scope of her movement. Marcus had been sitting up at 60 degrees, which was better than 30 degrees, and had been attempting to negotiate the television remote into a position his IV lines allowed for, and had been failing. She had fixed the IV line position and handed him the remote, and they had talked for 35 minutes about nothing in particular in the way of people who have known each other in circumstances that don't translate well into normal conversation, and who have found a register that works anyway. What did the review conclude? "A formal commendation is being added to your military record. It covers the Pratt incident and the Hale resuscitation." Rourke said it matter-of-factly, which was the right register. "Additionally, a flag has been removed from your separation file. The flag was administrative, related to the circumstances of your separation, and it's been reviewed and cleared." Claire absorbed that. The flag had been there for 3 years. It hadn't prevented her from working, but it had been a weight in the background of everything, a thing that could theoretically complicate situations that it hadn't complicated yet. "Thank you," she said. "It's accurate record-keeping," Rourke said. "It should have been cleared sooner." A pause. "I want to raise something with you. You don't need to respond today." "Go ahead." "There's a position. It's civilian, not military, contract-based, so you maintain your civilian status, and your nursing license is primary. It's with a federal medical training program that works with trauma response teams. The role would be based in Tucson. That was a consideration. And it includes a care support provision for dependent family members. The program is looking for people with dual-track experience, clinical and field." Claire stood in the break room. She'd taken the call during her afternoon break, and looked at the wall, which had a fire safety poster on it that she had looked at approximately 40 times in 4 months and had never quite read. "The care support provision," she said. "What does that look like practically?" "Coordinated access to specialist facilities, home support staffing, and transportation assistance. The specifics depend on the level of care required." Rourke's voice had a careful quality, not manipulative, more like she understood this was the variable that mattered most and was treating it accordingly. "I can get you the full documentation." "Send it," Claire said. "I'll look at it." "That's all I'm asking." She hung up and went back to her patients. Saturday morning was hers. Her father had a good day. He recognized her when she brought his breakfast, called her Claire without prompting, and asked about a neighbor from a house they'd lived in when she was 12, in a way that suggested his memory was working in the past tense, which was its own complicated gift. She sat with him for an hour after breakfast, not talking, just present, while a baseball game played on the television with the volume low. She went to the hospital in the afternoon. Not for work. She was off shift. She had a specific reason. She had received a message through the hospital's internal system from a patient she didn't know. The message was short. It said, My name is Daniel Pratt. I'm in the post-op ICU. I was told a nurse named Claire Sutton was the one who called for the cardiac imaging that caught what was wrong with me. I'd like to say thank you if that's possible. She went to the post-op ICU. Daniel Pratt was 29 and looked younger, the way people look younger when they're in a hospital gown with monitoring leads, and the normal defensive architecture of daily life has been temporarily removed. He had the arm that had been fractured in a brace, and the laceration above his eye had been sutured and was healing. He was alert and oriented and looked overall like a person who had been in a serious accident and had come out the other side of it, which was what he was. His wife was there, same age, sitting in the chair next to the bed with the posture of someone who had been in that chair for several days and was not leaving. There was a toddler in her lap who was attempting to eat a cracker and partially succeeding. "Ms. Sutton," Daniel said when she came in. He had been watching the door. "Mr. Pratt, how are you feeling?" Like someone cut open my chest, honestly. He said it without self-pity, just factual. "They told me it was an aortic dissection. They told me that if it had gone another 20 minutes without surgery..." He stopped. "You knew before the imaging." "I had a strong clinical suspicion," she said. "The imaging confirmed it. The surgical team repaired it. That's what saved you. But you're the one who made sure the imaging happened." He looked at her with the directness of someone who has been thinking about something for several days and has decided to say it plainly. The other doctor, Voss, he wasn't going to order it. She didn't confirm or deny that. She wasn't going to editorialize about another physician to a patient, regardless of what she thought. "I just want to know," Daniel said. "What made you know? What made you push for it when the other doctor didn't?" She thought about how to answer that honestly without saying the parts she couldn't say. "Experience," she said, "with a specific kind of injury, in specific circumstances. You see something enough times, your brain learns to recognize it before you've consciously processed the data." He nodded slowly. His wife, who had not said anything yet, said, "How many times did you have to see it for your brain to learn it like that?" Claire looked at her. The wife had brown eyes and the specific tiredness of a person who had spent the last 4 days not sleeping properly and was only now beginning to let herself feel how frightened she'd been. "Enough times," Claire said, which was the honest answer and the only one she had. The wife nodded. She adjusted the toddler on her lap. The toddler offered her the cracker, which was now approximately 40% eaten, with the generosity of someone who doesn't fully understand scarcity. The wife took a small piece of it and ate it, which was the right response. She was in the corridor outside the post-op ICU, heading back toward the elevator, when Sheila Graves caught up with her. Sheila Graves was the director of nursing, and she had been in that position for 9 years. And in those 9 years, she had seen a great many things happen in this hospital, some of them good and some of them not. And she had the look of a person who had developed a specific set of opinions about institutional behavior and had learned which ones to say out loud and which ones to keep filed in a particular cabinet. "Claire," she said, "do you have a minute?" They walked to the small consultation room near the nursing station, the kind used for family conversations, with chairs that were slightly better than the waiting room chairs and a box of tissues on the side table. Graves said, "I've been nursing director here for 9 years. In that time, I've seen 3 nurses file formal complaints about Dr. Voss. I've watched 2 of those complaints go nowhere. I've watched those nurses leave this hospital within a year of filing." She looked at Claire directly. "I want you to know that what happened this week, the QA investigation, the documentation review, it's the first time this institution has formally acted on a pattern that's been there for a long time. That happened because of you. Not only because of you, but you were the proximate cause." Claire said, "It happened because patients got hurt." "Yes. And because someone with your background documented things accurately and stood her ground when it would have been easier to let it go." Graves pressed her hands together. "I'm not a woman who says things I don't mean. I want to say, what you did this week and what you've been doing on this unit for 4 months has been noticed by people with the ability to act on it, even when it didn't feel that way." Claire looked at the box of tissues on the table. Institutional grade, the kind that weren't very soft. "Thank you for saying that," she said. "It was genuine. She meant it the way you mean things that you don't have a polished response for, which is sometimes the truest way." Graves left. Claire sat in the consultation room alone for a few minutes, which she needed, And then she went to the elevator and pressed the button for the lobby. The elevator opened on the ground floor and she stepped out and nearly walked into Briggs, who was standing in the lobby with a coffee and the expression of a person who had been waiting without minding the waiting. "Leaving?" he said. "Yes. Why are you here?" "Hale wanted someone to check on you today. I got the short straw." He said it deadpan, and she had been around soldiers long enough to know when deadpan was covering something genuine. "I'm fine." "Yeah, you look fine." He said it without sarcasm. He also said to tell you the step-down unit is less depressing than the ICU, and you could come see him when the television situation isn't as frustrating. She almost smiled. "Tell him I'll come by tomorrow." "I'll tell him." He started toward the elevator, then paused. "For what it's worth, and I know it's not my place, what you did Wednesday night after Voss removed you from that bay, going to Dom instead of walking away, that's not nothing." He looked at her. "Most people walk away." She looked back at him. "I know," she said. "That's why I didn't." She was walking through the lobby toward the main exit when her phone rang. Not Rourke. Not a hospital number. A number she didn't recognize with a Washington area code. She stopped. The lobby was busy. Saturday afternoon, visitor hours, family members coming and going through the automatic doors, a child running ahead of his parents, a volunteer with a cart of magazines moving toward the elevator. Normal. All of it completely normal. She answered. "Major Morgan," said the voice on the other end. Male, older, the particular register of command-level authority that she had not heard directed at her in 3 years. "My name is General Arthur Greer. I'm calling because a conversation has been started at a level above Colonel Rourke's jurisdiction, and I think it's time we spoke directly." A pause. "How much do you know about the program that Dr. Rourke mentioned to you?" "She sent me documentation," Claire said carefully. "I haven't finished reviewing it." "There's a section that wasn't in the documentation she sent," Greer said. "I'd like to discuss it with you, but I want to tell you something first before we get to the specifics." Another pause, longer this time, with the quality of a man choosing words that are accurate rather than convenient. "We've been reviewing what happened at Ridgecrest this week. The full picture, not just the incidents with Captain Hale. We've been reviewing 4 months of your patient outcomes on the MedSurg unit, the DVT catch, the Kowalski anticoagulation flag. 6 other cases in your documentation that the QA committee hasn't looked at yet, but that we have." She stood in the middle of the lobby with people moving around her and said nothing. "Major," Greer said, "the documentation tells a very clear story. And the story is that this hospital has been getting a level of clinical care in the last 4 months that it didn't know it was getting from someone it didn't know it had." He paused. "That changes today. And I want you to know, before I tell you what the section of the program documentation says, it changes in a way that is going to require decisions on your part. Significant ones." "Tell me," she said. And he did. She stood in the lobby of Ridgecrest Memorial Hospital on a Saturday afternoon, people moving past her in both directions, the automatic doors opening and closing, the ordinary machinery of a hospital in full operation around her. And she listened to what General Arthur Greer told her about the section of the program that hadn't been in the documentation. When he finished, she was quiet for a moment. Then she said, "When do you need my answer?" "Monday morning," he said. "But I think you already know what it is." The automatic doors opened. A gust of warm Tucson air came through, dry and desert-scented. A family walked in. 2 adults, 3 kids, the smallest one holding a helium balloon shaped like a star. "I'll call you Monday," she said. She hung up. She stood in the lobby a moment longer, and the thing she was feeling was not simple enough to name cleanly. It was a convergence of the last 4 months and the 3 years before them, and everything prior to that, all of it arriving at once in a hospital lobby on a Saturday afternoon, like a long-deferred bill finally coming due. Not a bad bill, just one that was real and significant and hers. She walked out through the automatic doors into the Tucson afternoon, and she did not look back at the building, and she pulled out her phone and called Mrs. Papadakis to confirm she'd be home by 5, and she got in her car. Monday was 2 days away. She drove. The drive home took 11 minutes. She knew because she counted, not deliberately, but the way you count things when your brain needs something concrete to hold on to while it processes something too large to take in all at once. 11 minutes, 4 traffic lights, One construction zone on the eastbound stretch of Grant Road that slowed her to a crawl for 90 seconds. By the time she pulled into her parking space, she had not made any decisions and had not tried to. Mrs. Papadakis was in the living room with her father when she came in, the two of them watching the tail end of a nature documentary about migratory birds, which her father had always liked. He looked up when she came through the door and said, "There she is," with the particular warmth of a man who is not always sure who she is, but is always sure she is someone important, which was, she had decided a long time ago, enough. She made dinner, simple, rice again, and the roasted chicken thighs her father could manage without difficulty, and a salad she ate mostly standing at the kitchen counter because sitting down felt like it would require being still. And she wasn't ready for that yet. Mrs. Papadakis left at 5:30 with the easy familiarity of someone who had become necessary without making a production of it, and Claire sat with her father through the evening news and then through the beginning of a program he fell asleep in the middle of, and then she got him settled and turned off the television and sat in the quiet living room with the lights low and thought about what General Greer had told her. The section that hadn't been in Rourke's documentation was about scope, not the clinical scope of the role. That part she'd read, and it was real and specific and matched something she could actually do. The scope she hadn't known about was the institutional scope. The program was in its formative stage, which meant the person who came in at this point would shape it. Not follow a structure that existed, build one. Curriculum, protocols, the framework for how combat-trained medical personnel were integrated into civilian trauma systems, and how civilian trauma knowledge moved the other direction, back into field medicine, which was a gap that had existed for years, and that nobody had properly bridged, because bridging it required someone who had lived on both sides of it, with enough fluency in both to know what was actually missing. She knew what was missing. She'd known for years. She'd been filling the gap informally, with her hands, in situations that weren't supposed to require it. The question was whether she was ready to do it formally, whether she was ready to stop maintaining the careful architecture of smallness she'd built around herself for 3 years. The short leases, the minimal footprint, the head-down execution of a job she was overqualified for, and do something that would require her to be visible, consistently. Not as the person who could be seen for 5 minutes in a trauma bay and then stepped back, but as the person whose name was on the program and whose face was associated with it, and who could not, when the situation required it, simply go back to the unit and document the encounter and let it pass. She sat with it for a long time. Then she went to check on her father one more time, and he was sleeping, and his breathing was regular. And she stood in his doorway for a moment, the way she always did, and she thought about the 11 years she'd been in the Army, and the 2 before that in nursing school, and the years since, and she thought about Walter Reyes and his left calf, and Daniel Pratt's asymmetric pulse, and Grace Ellerman's muffled breath sounds. And she thought about the 2 nurses before her who had filed complaints about Voss that had gone nowhere, and who had left this hospital inside a year. She thought, someone has to be the person who doesn't leave. Not out of stubbornness, not out of pride. Because the people who need the thing that person can do don't stop needing it when the person leaves. She went to bed. She slept better than she had in weeks. Sunday she spent with her father, largely. In the afternoon, she went to Ridgecrest and sat with Marcus for an hour in the step-down unit, which was in fact less depressing than the ICU. More light. A window that faced the courtyard with the mesquite tree. A television mounted at a height that did not require negotiating IV lines to operate. He was moving better than he'd been 2 days ago. Still cautious, still clearly dealing with the particular discomfort of a healing abdominal repair, but upright and present and engaged in the way of a person whose body is complaining and who is declining to give it the full vote. She told him about Greer's call. He listened without interrupting, which was something she appreciated about him. He didn't fill space when information was coming in. When she finished, he said, "What's the part that's making you slow down?" "The visibility," she said, "of the role. Of everything that comes with it, the record, the file. Once that's fully cleared and current and attached to something public-facing, the quiet life option is gone," he said. Yes. He looked at the window. The mesquite tree was doing the thing it always did, which was survive in an improbable location with limited resources, which was not a metaphor she was going to make anything of, but which she noticed anyway. "You've been protecting your father," he said. "That was the reason for the quiet life. The flag on your file. You didn't know when it would complicate things, and you couldn't afford complication. That's most of it. The flag is cleared now. I know. And the care provision in the program covers what you need for him. More than what I currently have, yes. He looked back at her. So what's actually left? She thought about it honestly, which was the only way she knew how to think about things that mattered. Habit, she said. 3 years of building something small and manageable and being good at keeping it that way. It becomes its own kind of comfort, even when you know intellectually that it's a constraint. Marcus nodded slowly. You know what I think? Tell me. I think the quiet life was the right call for when you needed it, and I think you've been maintaining it past the point where you needed it, because stopping felt like it required something, some permission, some event, some external, I don't know, trigger. He paused. Wednesday night was the trigger. You don't have to wait for a different one. She looked at him. That's the most words you've said consecutively in 3 years, she said. I've been saving them. Also, I've been in bed for 4 days, and I've had time to think. She almost laughed. It came out smaller than a laugh, but bigger than a smile, somewhere in between, the kind of response that's involuntary and therefore more honest than either option. I'll call Greer tomorrow, she said. I know, he said. You already decided on Friday. You just needed the weekend to make sure. She didn't deny it, because he was right. Monday morning, she called Greer at 8 o'clock. The conversation was 22 minutes long and covered the specifics she hadn't had time for on Saturday: timeline, structure, the administrative process for formalizing the contract, the care support coordination that would need to begin before she could fully transition. Greer was efficient and specific and didn't oversell anything, which she respected. At the end, he said, "We're glad to have you, Major." And she said, "Dr. Sutton works fine for the program context." And he said, "Understood." And she could hear that he did. She called Rourke next to confirm and to begin the care coordination process for her father, which was more complicated than a phone call, but which Rourke handled with the same methodical competence she'd brought to the hospital meeting, and which made Claire feel, for the first time in a long time, that she was not the only person managing the logistics of her own life. Then she drove to Ridgecrest, because she had a shift. The QA investigation findings came out on Thursday of the following week, which was faster than institutional processes usually moved, which meant someone had applied pressure from a level that made things move faster. Claire was on shift when the notice went to the nursing staff, a formal summary distributed through the hospital's internal communication system that outlined the findings without naming patients, and that concluded with a set of procedural changes to the surgical pre-authorization process and the protocol for nursing staff escalation in cases where clinical concerns were dismissed by attending physicians. The changes were specific and consequential. They included a formal process for nursing staff to request a second clinical opinion in cases of disputed assessment without requiring the approval of the attending whose assessment was being disputed. They included documentation requirements for cases where a nursing concern was formally rejected. They included a review mechanism that the Director of Nursing, Sheila Graves, would oversee. Claire read the summary at the nursing station between patient rounds. She read it twice. Then she filed it in her mental folder of things that had happened and that were real, and that she was going to take a moment to acknowledge before moving on, and she went back to her patients. What the summary did not include, because formal QA summaries don't include this kind of thing, was what had happened to Voss. That information came through other channels, at different speeds, the way information always moves through institutions, officially slow, unofficially fast. The formal channel, Dr. Harlan Voss's surgical privileges at Ridgecrest Memorial Hospital were permanently modified to require case-by-case review by the department's peer oversight committee for all procedures above a defined complexity threshold. His application for renewal of unrestricted privileges, which had been pending at the time the investigation opened, was denied. The Arizona Medical Board's formal review of the 2 prior nursing complaints, reopened in conjunction with the hospital's QA findings, resulted in a formal letter of reprimand added to his public licensing record, the first formal action on his record in 22 years of practice. The informal channel. Voss had been in conversations with 2 other hospital systems about a potential transition. Both conversations, according to what Tasha told Claire on Friday morning, with the specific energy of someone who had been sitting on information and had finally found the right moment, had gone quiet in the last week. One of the hospitals had pulled back entirely. The other was proceeding slowly, with additional credentialing requirements that hadn't been in their original process. None of that was a permanent end to his career. That was the truth of it, and Claire knew better than to expect a different truth. Institutions moved incrementally, consequences accumulated over time rather than arriving all at once. What had happened to Voss was real and significant and would follow him, and whether it ultimately amounted to full accountability or partial accountability or something in between was going to depend on factors she couldn't control and wasn't going to spend her energy on. What she could say with certainty was this: the next nurse who flagged a concern in Voss's pre-op bay would have a documented process to stand on. That was not nothing. That was, in fact, the thing that mattered most, because Claire Sutton was not going to be at Ridgecrest Memorial forever, and the system that protected the next person had to outlast the individual who'd forced it into existence. Her last shift at Ridgecrest was a Friday, 3 weeks after the week everything had changed. She hadn't announced it. The transition to the federal program was not public knowledge beyond the people who needed to know it, and she had told Owens and Graves with the same straightforward brevity she used for everything administrative, and both of them had responded with the kind of respect that doesn't require elaboration. The shift was unremarkable, which was not a complaint. Unremarkable shifts were the ones where the work was clean and the patients were stable, and the things that needed to happen happened without anyone having to fight for them. She did a thorough handoff on every patient she'd been managing. She wrote the cleanest, most complete documentation notes she'd written in 4 months, which was a high bar because she'd always written good notes. But there was something about a last shift that made her particular. Tasha found her in the break room at the end of the shift. "I heard," Tasha said. "News travels." "It always does." Tasha leaned against the counter with the posture of someone who has something to say and is figuring out how to say it. "Can I tell you something?" "Go ahead." "When you first got here, 4 months ago, the very first week, there was a patient in room 8 with a post-surgical fever that everyone was calling normal, and I thought wasn't normal. I'd been trying to get someone to listen for 2 shifts. You came in, I mentioned it, and you pulled his chart and spent 10 minutes doing a proper assessment and then called the attending directly." Tasha looked at her. "The attending didn't even know who you were yet. You just called." "I remember," Claire said. "He had a wound infection developing." "He did, and they caught it because you made the call." Tasha paused. "I've been thinking about that a lot this week, about what it looked like, says someone just doing the thing without checking whether it was going to be well received. It looked—" She stopped, restarted. "It looked like what I want to look like when I've been doing this for another 10 years. Claire looked at her. "You're going to look like that in 5, she said. "You already know what you're looking at. You just have to trust it." Tasha nodded and pressed her lips together and didn't say anything else, which was the right response to something that didn't need more words. On her way out, she stopped at the step-down unit. Marcus was being discharged the following morning. She knew because he had texted her, in the abbreviated manner of someone who had strong opinions about not using more words than necessary, the message consisting only of tomorrow 0900 finally. But she hadn't said a proper goodbye, and she was going to. He was packed, which was a relative term given that he'd arrived in field gear and had been wearing hospital gowns since. But the few things that had accumulated over 2 weeks, a phone charger, 2 paperback books Briggs had brought him, a completely unremarkable baseball cap, were in a bag by the chair. He looked good. Actually good. Not the managed version of good that people perform in hospitals. He had color back, and the careful way he'd been holding himself since the surgery had relaxed into something that was nearly normal. "I heard you're leaving," he said. "Friday is my last shift." "Where's the program based?" "They're setting up a facility on the south side of the city. Existing building needs some renovation. It'll take a few months before it's fully operational." She sat down in the chair by the window. "I'll be consulting with 3 other institutions in the interim and finishing the curriculum design." "You've already started it." "I started it in my head a long time ago." She paused. "I'll be here. In Tucson. Staying." He looked at her steadily. "Good. My father is being assessed by the new care coordination team next week. They're recommending a specialist facility with home support. It's about 4 miles from where we're living, better than anything I've had access to in 3 years." "Good," he said again, with the same weight. She looked at the mesquite tree through the window. It was there again, surviving. Marcus, she said. The night you came in. When you said my name in the corridor. Yes. You knew I would stay. He considered that. Not the quick response of someone who has the answer ready, but the slower consideration of someone who is being accurate. I knew you wouldn't walk away from a patient in a bad situation. That was a known constant. He paused. Whether you would stay in the larger sense, that I hoped. There's a difference. She nodded. Thank you for hoping. He didn't say anything to that. He didn't need to. She stood up, picked up her bag, and said, Stop tearing your abdominal muscles ahead of schedule. The post-op physiotherapy exists for a reason. I'm following the protocol. You're following 70% of the protocol and improvising the other 30. I've talked to your physio. He had the expression of a man who had been caught in a thing he was going to continue doing. I'll be fine. I know you will. She moved to the door. Take care of yourself, Captain. You too, Major. He said it the way he'd said her name in the corridor, not as a rank, as a recognition. Or Dr. Sutton, whichever sticks. We'll see, she said. She walked out. The hearing, the formal one, the last institutional proceeding in the sequence that had started with a chart thrown across a counter, took place on a Tuesday, 6 days later. It was not dramatic in the way that final hearings are sometimes portrayed. It was a conference room, a committee, a structured presentation of findings, and a formal vote. Claire was not required to attend, and she didn't. She was in the first planning session for the federal training program, sitting across a conference table from 3 people who were taking notes and who wanted to talk about curriculum framework, which was a conversation she had been waiting to have, in some form, for a long time. Rourke texted her during the lunch break. Formal findings upheld. Voss's unrestricted privileges permanently revoked at Ridgecrest. Medical board has opened independent review. Prior complaints reinstated in full. She read the text and put her phone back in her pocket and went back into the conference room. The 3 people across the table were competent and curious, and not yet sure what to make of her, which was fine. She was not yet sure what to make of the situation either, and she had found over the years that the most productive working relationships began in mutual uncertainty and became something solid through the work rather than through the introduction. So, said the woman running the session, Dr. Yolanda Fitch, program administrator, who had the careful efficiency of someone who had seen federal programs fail for lack of structure and was determined not to repeat the pattern. You said you want to start with the triage decision framework. Walk us through where you see the gap. Claire pulled her notes across the table. She'd written them by hand, which was a habit she'd never fully transferred to digital, and the pages were dense and specific, the kind of notes that contained more information per square inch than was obvious from a distance. The gap, she said, is that civilian trauma protocols are designed for institutions with full resources and clear role delineation. Field medicine is designed for zero resources and fluid role delineation. The 2 systems assume different things about the person making the decision, and when someone crosses between them, civilian to field or field to civilian, neither system has a framework for how to translate what they know. Which means, Fitch said, which means someone trained in a combat environment walks into a civilian hospital and either overperforms in ways the institution doesn't have language for or constrains themselves to the institutional expectations and operates below their actual capacity. She looked at the pages in front of her. Either outcome is a waste, and neither one is safe for the patient. The room was quiet for a moment. You're speaking from experience, the man to Fitch's left said. His name was Rafael Moreno, and he was a civilian trauma consultant who had been working with the program since its inception, and he had the look of someone who asked questions to confirm something he already suspected rather than to discover it. I am, she said. Both sides of it? Both sides of it. He nodded slowly, made a note. Then that's where we start. She turned to the first page of her notes. The room settled into the particular focused quiet of a group of people who have found the right starting point and are ready to begin. Outside, Tucson was doing what Tucson does in the late morning. Warm light, dry air, the blue clarity of a desert sky that doesn't apologize for being what it is. Her father's care coordinator was meeting with the specialist facility this afternoon. Marcus Hale was in outpatient rehabilitation, complaining about it appropriately, which Briggs had confirmed via text with the economy of a man who felt no obligation to use full sentences. The program was 3 months from being operational. There was work to do, more than she'd done in 3 years, and more consequential, and more visible, and none of that was something she could manage from the careful distance she'd been maintaining. She didn't want to manage it from a distance. That was the thing she had understood, somewhere between the parking lot and the drive home on Saturday and the quiet of her father's living room. The quiet life had never been who she was. It was what she'd chosen because it was what she'd needed, and that was a legitimate choice, and she didn't owe anyone an apology for it. But she was done choosing it now. Not because someone had told her to stop, not because a man on a gurney had said her name, not because a general had called with an offer, because she had done what she came to Ridgecrest to do. She had kept her father safe and stable. She had caught the things that needed catching. She had stood in the gap when the gap needed standing in, even when the institution told her the gap wasn't her problem. And she had done all of that without anyone knowing who she was, which had been necessary and was now finished. The thing about being underestimated, she had learned, not once but dozens of times, in different rooms, in different uniforms, in different versions of herself, is that it says nothing about the person being underestimated and everything about the limits of the estimator. You don't have to correct it publicly. You don't have to perform in order to be seen. You do the work, accurately, at the level it requires, and eventually the work speaks in a register that institutions cannot ignore. The cost of that is patience. A specific, sustained, sometimes brutal patience that asks you to keep going when the recognition hasn't arrived, when the documentation hasn't run, when the chart is still on the floor where someone threw it and no one has picked it up yet. She had paid that cost. What she was sitting in right now, this conference room, this conversation, this beginning, was not the reward exactly. Rewards implied transactions, and this wasn't a transaction. It was simply what came next when you kept doing the work and didn't let the institution's failure of imagination become your failure of nerve. Major Morgan, Fitch said, looking at her notes, you've listed here framework modules 1 through 7. How long do you estimate for the initial development phase? Claire looked at the page, at the 7 modules she'd sketched, each of which represented a gap she'd been living inside for years and had now, finally, been given space to fill. 4 months for the draft framework, she said. 3 more to pilot it. After that, we adjust based on what the data tells us. She pulled the cap off her pen. Let's start with Module 1, she said.